systemic pathology, and we're going to look at blood vessel disorders, and then touch on the blood vessel disorder and how it affects the heart. So today we're going to discuss a disorder referred to as arteriosclerosis, and then we'll look at atherosclerosis and its role in ischemic heart disease. Now that you are in systemic pathology, it is assumed that you still remember the principles that you were taught in the previous semester on general pathology, because some of those principles will be mentioned in most of the diseases that we're going to cover this semester. So today we're going to define what is arteriosclerosis. And of course, you can see it starts with artery and then now sclerosis. So we'll see what this disease is. We'll look at the various patterns of this disease. Then we'll look at atherosclerosis, which is also a disease encompassed in arteriosclerosis. We'll discuss the risk factors for the development of atherosclerosis, discuss how you actually form this atherosclerosis, the pathogenesis of this disease, then look at the clinical consequences. And one of the clinical consequences is ischemic heart disease, which we shall cover in detail today. So before I go into the actual diseases, it is important to know that diseases of blood vessels usually occur in two principal mechanisms. So one of the mechanisms is that you have a narrowing or a complete obstruction of a blood vessel lumina. Lumina is the opening, the lumen, that can occur either progressively. So that means that it is something that is occurring over a period of time, years, for example, atherosclerosis, which we're going to discuss, or it can be something that occurs abruptly. For example, when you form a clot inside a blood vessel, either the clot has formed there or it has embolized, it has moved from a different location. The other mechanism is usually weakening of blood vessels, and this usually results in either dilatation, or you can also have a rupture of these blood vessels. But for the purposes of this lecture, we shall not go into dilatation and rupture. We're going to discuss narrowing. It is important to know the normal architecture of a blood vessel, the normal anatomy, so that now when we discuss the various disorders that affect blood vessels, you can know which part of the blood vessel is affected, and the role that each part of the blood vessel plays towards the pathogenesis of a particular disease, for example, atherosclerosis. So blood vessels usually are fundamentally tubes. You've gone through anatomy. So blood vessels are tube-like structures that are usually composed of smooth muscle cells and an extracellular matrix with an inner luminal face covered by a continuous lining of endothelial cells. So within the lumen, there's a continuous lining of endothelial cells, and then beneath the endothelial cells is where you find these smooth muscle cells and extracellular matrix, which we're going to discuss in detail, especially when as far as atherosclerosis. So the amount of your smooth muscle cells and your extracellular matrix and the properties of your endothelial cells will vary throughout the vasculature depending on the unique functional needs of our blood vessels. For example, the aorta, from where most blood vessels come from, supplying blood to the entire body, the architecture of the aorta will be very different from a coronary artery, for example. So all this, the amount of smooth muscle cells and extracellular matrix will vary. So you'll find there are cells that are thicker, they're muscular as opposed to others. So as a result, to accommodate the pulsatile flow and higher blood vessels, arterial walls are usually thicker than that of veins, and they have invested several reinforcing layers of your smooth muscle cells. And within these arteries themselves, you're going to find that you'll have different architectures depending on the functional needs of the various arteries. So as arteries narrow to arterioles, the ratio of wall thickness to lumen diameter increases to allow more precise regulation of intravascular pressure. Because at the arterial level, you're just transporting blood and you require high pressures. At the arterial level is now when you're going into the specific tissue to bathe the cells with oxygen and other nutrients. So you require the lumen to be wider as opposed to the wall being thicker. So that's what it means. Veins, on the other hand, usually have distensible, thin-walled vessels, usually with high capacitance, because now they're receiving blood that has already washed the cells and various tissues. So to facilitate maximal diffusion, these arterioles, of course, they'll go and form capillaries. These are usually single cell linings of endothelial cells lying on a basement membrane, and this is to enable that diffusion of oxygen and nutrients across the vascular walls. So the thickness of the blood vessels is going to change depending on the function of that vessel. So blood vessels are usually organized into three layers. So when you cut a blood vessel, it has three layers, what is referred to as intima, media, and adventitia. So intima is the innermost part of a blood vessel, and this is what is lined by the endothelial cells. And then there's a layer that separates the intima from the media, and that is called the internal elastic lamina. Then we have the outer lining of the blood vessel, which is called the adventitia. So these layers are present in all vessels, but are most apparent in larger vessels and particularly in arteries. So the intima usually consists of your endothelial cell monolayer on a basement membrane with minimal underlying extracellular matrix, and it is separated from the media by a dense elastic membrane called the internal elastic lamina, which I've said separates the intima from the media. The media, on the other hand, is composed predominantly of smooth muscle cells and extracellular matrix surrounded by loose connective tissue. It also has nerves, fibers, and small vessels of the adventitia. So the blood vessel itself, as much as it is transporting blood to other parts of the body, remember it is also tissue. It has cells, and these smooth muscle cells, extracellular matrix, they all require oxygen. They all require nutrients. So there are also blood vessels that supply the blood vessels themselves. So that's why we're saying in your media, you have loose connective tissue, you have nerves, and you also have smaller vessels. Then we have an external elastic lamina, which is present in some arteries and defines the transition between the media and the adventitia. So diffusion of oxygen and nutrients from the lumen is adequate to sustain thin-walled vessels like your capillaries and the innermost smooth muscle cells of all vessels. But where you have larger vessels and medium-sized vessels, you need small arterioles within the adventitia, which are called the vasa vasorum, vessels of vessels, which perfuse the outer half of the two-thirds of the media. So if you have thick blood vessels, you also require other blood vessels to be able to perfuse this blood vessel so that it can be able to have enough nutrients and oxygen. And those blood vessels are called vasa vasorum. So knowing the normal architecture of blood vessels, let's now go into the various disorders that affect blood vessels. So we have what is called arteriosclerosis, and arteriosclerosis basically refers to hardening of arteries with loss of elasticity of the blood vessels. And elasticity is usually important so that blood can move within these blood vessels. So this arteriosclerosis has various types. So we have what is referred to as arteriolosclerosis, and this is usually a disease of small arteries and arterioles. And there are two types of this arteriolosclerosis. It can be hyaline or it can be hyperplastic arteriolosclerosis. We're going to discuss this. There's also another type of arteriosclerosis. So note the difference. Arteriosclerosis, arteriolosclerosis. Then we have Mockenberg mediosclerosis. And in this disorder, you have calcium or deposits, calcific deposits in muscular arteries. Usually, you'll have depositions in the internal elastic lamina. I've shown you where this is. And this is a disease that occurs in patients who are more than 50 years of age. And most of the time, it does not result in luminal narrowing and therefore is usually an incidental finding with no clinical significance. Another disorder is your fibromuscular intimal hyperplasia. And then we have atherosclerosis, which I said we're going to discuss in detail. So let's look at arteriolosclerosis. And we say there are two types. You have hyaline and you have hyperplastic. So for hyaline arteriolosclerosis, this is a blood disorder that is usually blood vessel disorder that is usually associated with benign hypertension. So most of the patients who have hypertension eventually will develop hyaline arteriolosclerosis. It can also be associated with aging, and it can also be associated with diabetes, but most of the time it will be seen in patients who are hypertensive. The reason why it's called hyaline arteriolosclerosis, it's because it is characterized by a pink hyaline vessel wall thickening and luminal narrowing. And this usually results where you have endothelial cell damage. So you have damage to endothelial cells, the innermost lining, and then you have leakage of plasma components. Remember, blood is composed of blood cells and plasma. So this plasma leaks now into your media. And when it leaks into the media, it leads to the activation of your smooth muscle cells, and you have increased extracellular matrix production. Always remember, from normal physiology, every part of the body is in homeostasis. So even in a blood vessel, there's a required amount of smooth muscle cells and there's a required amount of extracellular matrix. So that if either exceeds the required amount, then you get a disorder. So in hyaline arteriolosclerosis, you begin with endothelial cell damage, then you have leakage of plasma proteins coming from the blood that is within the blood vessels, and then you have activation of your smooth muscle cells that are usually in the media, and these smooth muscle cells now lay more extracellular matrix, and this results in the thickening of your blood vessel. And then, of course, when your blood vessel becomes thicker, then you're going to have narrowing of the lumen. So this is an example of hyaline arteriolosclerosis. So you can see this blood vessel, and you can see in the wall is thick. It is composed of this pink amorphous material. So that's the plasma protein that entered the media, led to more deposition of your extracellular matrix, and you have that thickening. So this can also affect blood vessels in the kidney, and that's why one of the effects of diabetes and also hypertension is to eventually lead to a chronic kidney disease. You know that this is one of the major causes of CKD that leads to dialysis. So A just shows you the normal anatomy, the normal histology of your kidney. Then B is trying to show you blood vessels within the kidney that are undergoing your hyaline arteriolosclerosis, and you can see the thickening of the wall of this blood vessel. You can compare it to the one that's sitting next to it. It's open, but this other one has thickening of the wall, and you can see the lumen of the blood vessel is becoming smaller and smaller and smaller. And when this affects many blood vessels within the kidney, then we'll refer to that as global glomerulosclerosis, and this will lead to chronic kidney disease, and eventually that patient will require dialysis. The other type of arteriolosclerosis is hyperplastic arteriolosclerosis. And this is associated with severe hypertension. You'll have a lecture on hypertension and hypertensive heart disease, and you're going to learn about the different types of hypertension. So for hyaline, it's caused by benign, what normal population with hypertension usually have. This disease that is just chronic. As long as you're on medication, you're okay. But there are times when this can be severe, and when that happens, you form hyperplastic arteriolosclerosis. So in hyperplastic arteriolosclerosis, the vessels usually exhibit an onion skin concentric laminated thickening of the arteriolar wall, and this of course will lead to luminal narrowing. So when you cut an onion, you know how it looks like, the rings of an onion. So the hyperplastic arteriolosclerosis gives almost a similar appearance, but now this is on blood vessels. So the laminations usually consist of your smooth muscle cells and thickened, reduplicated basement membrane. And you can also have malignant hypertension, fibrinoid necrosis, and this we refer to as necrotizing arteriolitis. I remember fibrinoid necrosis when you had a lecture on cell injury and also necrosis. So this is an image of our kidney tool. So this is a histologic segment of our kidney, and you can see this blood vessel. It almost looks like an onion. So you have that concentric laminated thickenings of a blood vessel, and you can barely appreciate the luminal opening of this blood vessel. So you get occlusion of your lumen. So that's with arteriolosclerosis. Remember, there are two types, hyaline and hyperplastic. Then the other disorder we said is fibromuscular intimal hyperplasia. And this, as the name suggests, involves muscular arteries, and it usually occurs after an inflammatory process, e.g., in patients who have had transplants, where you had infection or inflammation of your blood vessels, what is called healed arteritis, or where you have mechanical injury to blood vessels, e.g., where you have to put stents. Like, for example, in patients who have coronary artery disease, they have occlusions, they have atherosclerosis, you have to put stents. So the side effect of that is that it leads to an inflammatory process that can then result in fibromuscular intimal hyperplasia. So as this disease suggests, there is smooth muscle hyperplasia with extracellular matrix deposition that may result in vessel stenosis. And this disease is actually one of the major long-term limitations of solid organ transplants. So that's why I'm sure you've heard, even after a kidney transplant, 15 years after that, you still need another kidney. And one of the reasons is also the development of this fibromuscular intimal hyperplasia that affects blood vessels of that transplanted organ. And when there's no blood flow to an organ, of course, it's going to die, and the patient will require a new one. So this is just a histologic image to demonstrate the same. So you can see this is a large muscular artery, and you can see the thickening of the wall. Yeah, so you can see prominent concentric fibromuscular intimal hyperplasia, and in this case, you can barely appreciate the lumen. It's like a slit-like opening, and this is due to you have smooth muscle cells, myofibroblast, and collagen that have been deposited onto the wall of this blood vessel, leading to that hyperplasia and narrowing of the lumen. Actually, this is a liver. This shows me this is a liver, and of course, you know that in there are countries where they do liver transplants. So as you take maybe the transplant organ, you can tell that one of the reasons for rejection is that in this organ there is fibromuscular intimal hyperplasia. Let's now discuss atherosclerosis. And atherosclerosis is a slowly progressive disease that affects large to medium-sized muscular and elastic arteries. It is characterized by intimal lesions called atheromas, hence the name atherosclerosis. Other books will refer to these atheromas as atheromatous or atherosclerotic plaques. Remember, slowly progressive disease that affects large to medium-sized muscular and elastic arteries, characterized by intimal lesions called atheromas, hence the name atherosclerosis. These atheromas or atheromatous plaques are usually composed of lipid cores covered by fibrous caps. This lipid cores covered by fibrous caps can grow to the extent of obstructing the lumen, or they can cause abnormalities in the wall architecture, leading to rupture of the blood vessel, and this leads to formation of a blood clot, which will also obstruct the lumen. So plaques, like I've said, they will weaken the underlying media, and this can not only lead to rupture, but then you can also form aneurysms. We're not going to discuss aneurysms, but those you'll hear about abdominal aortic aneurysms, cerebral aneurysms. Most of them result as due to atherosclerosis weakening the blood vessels, causing them to dilate. Of atherosclerosis, coronary artery disease. This, remember, coronary arteries affect the diseases, are the blood vessels that nourish the heart. So coronary artery disease is a very important manifestation of atherosclerosis. And this coronary artery disease leads to ischemic heart disease, which we're going to discuss today. And it's the leading cause of death worldwide. And all this results from the blood vessel disorder referred to as atherosclerosis. So for you to develop atherosclerosis and in turn ischemic heart disease, there are various risk factors, some which you can change and others you cannot change. So we have what are called constitutional or non-modifiable risk factors. These are risk factors that you cannot change. For example, it's genetics. So how you metabolize lipids within your body. Some of these things you inherit or you acquire, and you cannot change them. So you can easily form atheromatous plaques because of how your body deals with lipids. Then age. Atherosclerosis, we've said, is a progressive disease. So incidence increases with age. So as you age, then the chances of forming atheromas and atheromatous plaques increases. The other thing is gender. Atherosclerosis is more common in males, and its effects, ischemic heart disease, is more common in males than females, especially the ones before menopause. And this is because estrogen produced by females has a protective effect against lipids. But once women become menopausal, that estrogen effect goes down. And for postmenopausal women, they have the same risk as males. But for the perimenopausal women, they have an estrogen protective effect. But the incidence of ischemic disease in postmenopausal women now equals that of males when now they reach that age. The other thing is family history. There are genetic abnormalities that run within families. I don't know whether you learn about this, but there are conditions called familial dyslipidemias, where you have various abnormalities in genes that affect lipid metabolism, and this run within families. Then we have modifiable risk factors or unconstitutional risk factors. These are things that you can change. And one of them is hyperlipidemia. And what causes hyperlipidemia? Diet. If you consume a diet that is high in LDL cholesterol, which we call low density lipoprotein cholesterol or bad cholesterol, more than diets that are high in the high density lipoprotein HDL cholesterol, then you're more likely to develop atherosclerosis. LDL cholesterol is referred to as bad cholesterol because it is the cholesterol that removes cholesterol from the liver where it should be stored to now tissues. So it can take it to blood vessels for it now to form atheromatous plaques. HDL cholesterol is now what takes cholesterol from the tissues to the liver. So the target of your diet should always to have high HDL as opposed to LDL. But if your diet consists of more LDL than HDL, then you are at a higher risk of developing atherosclerosis. Then there are also other foods that are protective against atherosclerosis. For example, foods that are rich in omega 3. Just a minute. So yes, I was discussing diet. So you have to have dietary intake that is high in HDL as opposed to LDL. Also, you can have certain foods that give you good cholesterol, like for example, the foods that have omega 3, and these are usually your fish, like your salmon, your sardines, also certain plant-based foods like walnuts, chia seeds. They're usually rich in omega 3, and these usually increase your HDL cholesterol. Also, exercise has been shown to increase HDL cholesterol. Um, then this is controversial. Red wine, but if you take moderate, not excessive consumption, also increases your HDL cholesterol. Also, those patients who are on statins, and these are drugs that lower cholesterol, of course, they're going to avert this hyperlipidemia. Then we have hypertension as the other modifiable risk factor. So patients who are hypertensive, one of the effects is they are going to develop atherosclerosis, and that's why you will find in clinical practice patients who have hypertension and diabetes are started on statin therapy, and this is to control their lipids and avert the effects of atherosclerosis. So hypertension usually results in endothelial injury, and we're going to see the pathogenesis of atherosclerosis, which starts with endothelial injury. Then we have cigarette smoking. Of course, cigarettes, they have toxins that cause endothelial injury, and this is usually the propagating event that leads to atherosclerosis. Then diabetes is also another risk factor. What diabetes does, it raises circulating cholesterol levels, and diabetes itself is associated with an increased risk for stroke and a 100-fold increase in atherosclerosis-induced gangrene of the lower extremities. They get what is called peripheral vascular disease, and that's why you find diabetic patients develop diabetic foot. One of the pathogenesis is the atherosclerosis. Then the other risk factor is inflammation. So anything in your body that can lead to inflammation, because inflammatory cells are usually present during all stages of atheromatous plaque formation, and they are intimately linked with plaque progression and rupture. So those who have inflammation because they have autoimmune disease, stress can cause inflammation, nutritional deficiencies can lead to inflammation. So anything that can lead to inflammation can propagate atherosclerosis. Then we have what is called hyperhomocystinemia, which is also a condition where you have high cysteine levels, homocysteine levels, and these are associated with endothelial damage. Then we have high levels of lipoprotein A, which is usually like an LDL-like protein. It's actually considered more lipogenic than LDL. It transports more cholesterol to tissues than LDL itself. And when you have high levels of lipoprotein A, then you are at a high risk of having atherosclerosis. And when you have these high levels, they will increase your risk of coronary artery disease and also cerebrovascular disease, which will lead to strokes. Then patients with metabolic syndrome. Metabolic syndrome is a condition that's associated with central obesity. They have central obesity. They have insulin resistance. These patients have hypertension. They have dyslipidemias. They have very high lipids. They have a hypercoagulable state. It is also a pro-inflammatory state, and all this predispose to an increased risk of atherosclerosis. So what is the pathogenesis of this atherosclerosis? How do you form these atheromatous plaques? So atherosclerosis, we've said, is a slowly progressive disease that affects your large blood vessels, and it is postulated to occur in response to injury. That is where you have a chronic inflammatory response to endothelial injury. So the initiating event is usually endothelial injury, and we've seen some of the things that will lead to endothelial injury: hyperlipidemia, hypertension, smoking, diabetes. So you start with endothelial cell injury. When you have endothelial cells being injured, they become dysfunctional. So when your endothelial cells are dysfunctional, they allow seepage of substances from your blood into now the wall of the blood vessel. So you have increased permeability. Also, where you have endothelial dysfunction, leukocytes are able to adhere to those endothelial cells, and also you can have the disruption enough to cause thrombosis. One of the things that is going to seep now that you have increased permeability is your lipoprotein. So you'll have accumulation of lipoproteins, mainly oxidized LDL and cholesterol crystals in the blood vessel wall. So these are leaping as are leaking from your, remember these lipids are within your blood. So blood transports all sorts of substances. One of them is lipids. So when you have endothelial dysfunction, these lipids are now leaking from the blood vessel lumen into the wall of this blood vessel. Where you have endothelial cell activation, you'll also have platelet adhesion. You'll have one of the leukocytes that will adhere are your monocytes, and this will migrate into the intima and they will differentiate into macrophages and foam cells. Monocytes are in blood. When they get into tissue, they become macrophages. Then you'll have lipid accumulation within these macrophages, which responds by releasing inflammatory cytokines. So when lipids accumulate within macrophages, they're referred to as foam cells. I have a diagrammatic representation of this. Then when you're releasing these cytokines, what are you doing? You're activating your smooth muscle cells, and these smooth muscle cells will proliferate and deposit more extracellular matrix, and then you end up having an atheromatous plaque. So this you're going to find in your Robbins. We've said that your blood vessel, the normal blood vessel consists of an endothelium. Then you have your internal elastic lamina, you have your media, and then you have your adventitia. So the pathogenesis of atherosclerosis first starts with damage to this endothelium. And this damage to endothelium can be caused by your hyperlipidemia, hypertension, smoking, high levels of homocysteine, hemodynamic factors, toxins, viruses, immune reactions. For those who have autoimmune disease, the first initiating event is chronic endothelial injury. Once that happens, you get endothelial dysfunction, which leads to increased permeability. So you start having leakage. You have this dysfunctional endothelial cells are able now to release certain adhesion molecules. So you end up having leukocyte adhesion, you have monocyte adhesion, and then you have migration of these monocytes from your blood into your tissue, when now we call them macrophages. So the two most important causes of endothelial dysfunction are your hemodynamic disturbances and where you have hypercholesterolemia, which we're calling hyperlipidemia. So your hemodynamic disturbances are where there's very high pressures, like where you're branching, where blood vessels are branching off. So plaques tend to occur at ostia of exiting vessels, where the exiting vessels are branching off from a main artery, at branch points and along the posterior wall of the abdominal aorta, where there is turbulent blood flow. So these are the areas where you're most likely to find atherosclerosis. For your hypercholesterolemia, these lipids typically are transported in the bloodstream, and they're usually transported bound to specific apoproteins, forming lipoprotein complexes. That's what we're talking about: LDL, HDL, lipoprotein A, ApoB. There are so many transport proteins. So these lipoproteinemias can also result from mutations in genes that encode apoproteins or lipoprotein receptors. We've talked about one of the non-modifiable risk factors being genetics. So if you have any mutations in genes that encode apoproteins or lipoproteins, they're going to affect how you handle cholesterol. You can also have certain disorders that derange lipid metabolism. For example, patients who have nephrotic syndrome, you're going to learn about nephrotic syndrome this semester. In those who are alcoholics, in hypothyroidism, or in patients who have diabetes mellitus. They have deranged lipid metabolism and they end up having increased lipids within their bloodstreams. So the dominant lipids in atheromatous plaques are usually your cholesterol and your cholesterol esters. So lowering serum cholesterol by diet or drugs slows the rate of progression of atherosclerosis. So you can have hemodynamic disturbances, but if you do not have hypercholesterolemia, then you're unlikely to have progression of your atheromatous plaques. But if you have these hemodynamic disturbances and you have the rest, you have hypertension, you have diabetes and all that, as long as your endothelium is damaged, then the probability of developing atheromatous plaques becomes increased. So where you have chronic hyperlipidemia, so for extended periods of times, your lipids are high, particularly those who have hypercholesterolemia. This usually can directly impair endothelial cell function by increasing local oxygen-free radical production because you have excess amounts of your cholesterol. These dysfunctional endothelial cells, I've said, once they're damaged, they express adhesion molecules that promote leukocyte adhesion, particularly monocytes and your T cells. Your LDL is oxidized through actions of oxygen-free radicals that are usually generated locally by macrophages or endothelial cells, and they are ingested by macrophages through a scavenger receptor, resulting in form cell formation. So when these macrophages adhere and they migrate into the intima, then they become macrophages. Then these lipids that are leaking from the blood into this intima, they are phagocytosed by these macrophages. And when these macrophages phagocytose the lipids, they're now called foam cells. So the LDL stimulates the local release of growth factors, cytokines, chemokines, and this increases monocyte recruitment. So you have more monocytes migrating, and it is also cytotoxic to endothelial cells, causing more endothelial cell damage, and this is also toxic to your smooth muscle cells. So all this leads to activation, more production of cytokines, more production of growth factors, exacerbated endothelial injury. Then you continue having leakage or of these lipids that are in the bloodstream into the tissue that are continuing to be absorbed, and then you end up forming an atheromatous plaque. So when you have macrophage activation, smooth muscle recruitment, and accumulation of lipids within the blood vessel wall, this leads now to the propagation and formation of these atheromatous plaques. We've said that these macrophages that have been activated and the engulfing lipids, you have formation of what are called foam cells. So your smooth muscle cells can also engulf lipids, and you form these cells that have these lipids within them, and these are called foam cells. So once you activate these macrophages, remember macrophages and smooth muscle cells also produce cytokines, and all these will lead to smooth muscle cell proliferation. These smooth muscle cells, once they proliferate, they secrete more extracellular matrix, and therefore now you have growth of this plaque within blood vessels. So how do these plaques appear? When you take a section of your blood vessels. So these atheromatous plaques develop and grow slowly. We've said it's a progressive disease that occurs over decades following a series of morphologic changes. So the first thing that forms is what we call a fatty streak. So this is minute yellow flat macules that coalesce into elongated lesions, usually about a centimeter or more in length, and they're usually composed of lipid-filled macrophages. So you had endothelial cell damage, and then you have a few macrophages that have engulfed the lipid. So this is usually the first structure to form. So these fatty streaks, they can appear in the aortas of infants younger than 1 year of age, and they're usually present in virtually all children older than 10 years of age, regardless of genetic, clinical, or dietary risk factors. So everyone has fatty streaks from the beginning. But of note is that not all fatty streaks are destined to progress to atherosclerotic plaques. So what makes you progress are now what we are referring to the modifiable risk factors. So your diet, your hypertension, your diabetes, all this now leads to the progression of these fatty streaks to formation of atherosclerotic plaques. Nevertheless, it is notable that coronary fatty streaks form during adolescence at the same anatomic sites that are prone to plaques later on in life. And these are what now will propagate coronary artery disease. So this is just an image. You can see these flat yellow macules. This is the abdominal aorta. You can see these are forming near osteas where we said that they are hemodynamic disturbances. This is the back of the abdominal aorta that is usually susceptible to hemodynamic disturbances, and this is where you're seeing these fatty streaks. Just macrophages with lipid droplets within them. This is a histologic image of a fatty streak. Then the next thing is so from fatty streaks, you now form atherosclerotic plaques. And the key features of these lesions are intimal thickening and lipid accumulation. So these atheromatous plaques are usually white to yellow raised lesions that range from 0.3 to 1.5 centimeters in diameter, but they can coalesce together to form larger masses. And actually, in more cases, even at autopsy, what we see are usually larger lesions. So these are plaques that have coalesced together to form larger lesions. So local flow disturbances such as turbulence at branch points make certain parts of blood vessels especially susceptible to plaque formation. So in descending order of severity, you're more likely to see atherosclerosis. So the commonest site where you see atherosclerosis is the infrarenal abdominal aorta. Just after the renal vessels have branched off, you see atherosclerosis in the infrarenal abdominal aorta. The other blood vessels that are susceptible to atherosclerosis are your coronary arteries, and we've said the most important clinical manifestation of atherosclerosis is coronary artery disease that leads to ischemic heart disease. Then we have popliteal arteries, where is the commonest place where you form deep venous thrombosis, the popliteal arteries. Why? Because of atherosclerosis. Then we have the internal carotid arteries and the vessels of the circle of Willis. And that's why the other common manifestation of atherosclerosis is cerebrovascular diseases, where they get strokes. So even in the same patient, atherosclerosis typically is more severe in the abdominal aorta than in the thoracic aorta, and a patient can have atherosclerosis in all of these blood vessels, but it will be more severe in certain blood vessels than others. When you look at an atheromatous plaque under a microscope, it is usually composed of three principal components. You will find cells. So you'll see your smooth muscle cells. We've talked about macrophages and T cells being recruited. Then you'll have extracellular matrix, which is composed of collagen, elastic fibers, and proteoglycans. And then you'll have intracellular and extracellular lipids. Intracellular is the lipids that is in the foam cells, what has been engulfed by your macrophages and your smooth muscle cells. But you'll also have extracellular lipid because we've said you have endothelial dysfunction, you have increased permeability, and therefore you still have leakage of these lipids into the intima, and therefore you're going to still have extracellular lipid. So plaques have a superficial fibrous cap composed of your smooth muscle cells and relatively dense collagen. So we said that it's your cholesterol esters that are covered by a fibrous cap. And this fibrous cap is because of the smooth muscle cells that now lay down collagen and extracellular matrix, and you end up having this cap-like lesion. So deep to the fibrous cap is a necrotic core containing lipids, primarily your cholesterol and cholesterol esters. You will see necrotic debris. These cells, as much as they're engulfing the lipids, remember all cells have a half-life. Like macrophages, they have a half-life, so they will die, and therefore you're still going to see necrotic debris. You'll see lipid-laden macrophages. You'll see your smooth muscle cells that have engulfed your lipids. You'll see fibrin. You'll see variably organized thrombus if there was a rupture that led to thrombosis, and you'll also see other plasma proteins. So plaques generally progressively enlarge over time through cell death and degeneration, synthesis and degradation of your extracellular matrix. So there's remodeling, and you can also have where there's clot formation, like if there's a bit of a rupture, then you get a clot formation. You'll also have thrombus organization. Atheromas can also undergo calcification. You are taught calcification, metastatic and dystrophic calcification. In this case, you'll have dystrophic calcification because these are damaged blood vessels. So you'll have dystrophic calcification. So this is how atheromatous plaque usually looks like. So you have a necrotic center, which we said it has cellular debris, cholesterol crystals, foam cells, and calcium. And then, of course, you had your smooth muscle cells, your macrophages, your foam cells, your lymphocytes, and the smooth muscle cells that have laid down collagen, elastin, proteoglycans. You have formation of new blood vessels, and this is now the component of your fibrous cap. And we've said that atherosclerosis is an intimal lesion. It affects the vessel intima because you can see the media is not affected. And we said that there is that internal elastic lamina that separates the intima from the media. So this is usually an intimal lesion, not a medial lesion. So you can see this. This is our abdominal aorta. This was obtained from autopsy, and you can see these atheromatous plaques, and then they're coalescing together to form larger lesions. And then these are plaques that have undergone rupture. And of course, where you have rupture, you have exposure of thrombogenic material, and you end up forming thrombus. So you can see some ulceration, and then you have superimposed thrombus formation. So these atheromatous plaques can form in two ways. You can either form stable or unstable plaques. So stable plaques usually have a dense fibrous cap. They have minimal lipid accumulation, and they have little inflammation. And this usually will produce symptoms related to chronic ischemia by narrowing of vessels. Because they have a dense fibrous cap, how they're going to cause symptoms is that when they progressively grow, then they continue to occlude the lumen, and therefore you'll have symptoms related to chronic ischemia because you have progressive narrowing of your blood vessel. For the unstable plaques, on the other hand, they usually have thin caps They have larger lipid cores and they have a relatively dense inflammatory infiltrate. We said leukocytes are going to enter into this plaque. So unstable plaques are dangerous because they're unstable, they can easily rupture and they can cause dramatic and potentially fatal ischemic complication that are related to acute plaque rupture. And when you have plaque rupture, you get thrombosis, or where you have rupture and you have release of the substances that are within this plaque, then they go and embolize in other vascular beds and cause effects on those vascular beds. Like, for example, if it embolizes and goes to the brain, then it will cause ischemia in the brain. If it goes to the kidney, it's going to cause ischemia in the kidney. So those are the effects of these atheromatous plaques. These atheromatous plaques can undergo changes, and these changes are what leads to the symptoms that occur as a result of these plaques. So these changes are clinically significant. So one of the changes that can occur in atherosclerotic plaques is they can rupture, or they can ulcerate, or you can have erosions. So these occur on the luminal surface of the atheromatous plaques, what is facing where blood flows. And when you have a rupture, you have exposure of thrombogenic substances that induce thrombus formation. We already went through clot formation in general pathology. So you have exposure of your thrombogenic agents, and then they lead to thrombus formation. You have platelet aggregation, you have activation of the coagulation pathway, and then you end up having formation of a clot. So this clot may partially or completely occlude the lumen, leading to tissue ischemia. So let's say you have an atheroma of a coronary artery, then that atheroma ruptures. So you end up having occlusion of a coronary artery, and that is what is going to lead to a myocardial infarction, or what we call a heart attack. If this occurs in the vessels of the circle of Willis, which is in the brain, or in the carotid arteries, then blood flow to the brain is compromised. So you can see the detrimental effects that can occur as a result of the atheromatous plaques. These thrombi also become organized, and they can be incorporated into the growing plaque. Of course, your body has a system of absorbing these clots. So this is what we're calling the organization. And this is just an image to show the same, that you have atheromatous plaques that have ruptured, and you have superimposed thrombi on them. But in this case, these thrombi have organized. The other plaque change that can occur is hemorrhage into a plaque. So where you have rupture of the overlying fibrous cap, then the blood that is within the lumen will now enter inside the plaque. Or we've said that in this plaque, you still have formation of blood vessels, and these blood vessels can also rupture. So you have hemorrhage within the plaque itself. So you end up having expansion. So if blood is accumulating within this atheroma, then it will expand, and eventually it can occlude the blood vessel, or that expansion can now lead to further rupture that has the detrimental effects that we have discussed. So this is just an image to demonstrate that in this case you have blood that is seeping into the atheromatous plaque, and here it has started to become organized. But this is the vessel lumen. This was the atheromatous plaque that was forming. Then you have a small rupture there, and you have blood entering into this atheromatous plaque. You can have atheroembolism, where a ruptured plaque can discharge debris into the blood, producing microemboli composed of plaque components. So the cells, the lipid cause, now once you have rupture, you have release of these substances. So they can go and occlude a blood vessel. The other thing we said is that these intimal lesions, they lead to weakening of your blood vessel wall that can lead to aneurysm formation. So atherosclerosis induced pressure or ischemia, atrophy of the underlying media with loss of elastic tissue causes structural weakening that can lead to aneurysmal dilatation, and it can also lead to rupture of blood vessel. So this cup is sitting on a blood vessel, so it can cause pressure occlusion, or you have this loss of blood supply to the rest of the blood vessel. This leads to weakening of the blood vessel, and this can lead to dilatation or rupture. So what are the consequences of this atherosclerosis? Of course, we've discussed the changes that can occur, rupture, hemorrhage, atheroembolism, aneurysm formation. But it is important to know that at early stages, you usually have remodeling of the media that tends to preserve the luminal diameter by increasing the vessel circumference. So your body adapts. Remember the first lecture you had in pathology about cellular adaptation. So your body adapts. But owing to the limits of remodeling, eventually this expanding atheroma will eventually impinge on blood flow. Then you reach a point what is referred to as critical stenosis, and this is the tipping point at which chronic occlusion limits flow so severely that tissue demand exceeds supply, and therefore this patient will start presenting with symptoms. If this is in the heart, these patients are going to start having chest pains. So in the coronary artery and other circulation, this typically occurs at approximately 70% fixed occlusion. So if your blood vessel occlusion reaches 70%, then that's the tipping point, and this patient will start presenting with features of ischemia because tissue demand exceeds the supply. At rest, most of these affected patients will have adequate cardiac perfusion, but with even modest exertion, demand exceeds supply and chest pains develop because of cardiac ischemia, and this is what we call stable angina. We're going to discuss this in a few minutes. So the toll of chronic arterial hypoperfusion due to atherosclerosis in various vascular beds includes you can get vascular ischemia if this atherosclerosis affects mesenteric arteries. You can have sudden cardiac death if this affects a major coronary artery. You can have chronic ischemic heart disease. We're going to discuss this. You can have ischemic encephalopathy when you affect the blood vessels of the brain, and you can have what is referred to as intermittent claudication or ischemic leg pain. This is a precursor to your peripheral vascular disease. So we've said that infarct streaks, you will find them in virtually all children greater than 10 years of age. But now what leads to the progression or into an atheromatous plaque now will depend on your modifiable and non-modifiable risk factors. And then now when you have this plaque formation, it can undergo rupture, or you can form an aneurysm. You can